EV-related toxicities, are there any early interventions that you practice for your patients or that you suggest for clinicians watching this?
Um, so there are some toxicities that happen in almost every patient. I have seen, in terms of like itchiness or rash, dry skin. So informing patients about that, and one of the things about the rashes I have also seen is that patients over time they do get used to it. Like their rashes are not. If you can, if you treat the initial first cycle, second cycle rash with steroid creams or topical moisturizers, and then they somehow with ongoing treatment don't have rashes as bad. The body somehow
Right.
adjusts to it. Blurry vision and eye toxicity is something that is we're kind of coming more into picture now that we are seeing more and more patients. So if patients mention about blurry vision or dry eyes, then sending them to an ophthalmologist early on is a good idea because they do benefit from steroid eye drops.
Mm-hmm.
And then neuropathy is something it is always in the center of our mind because it's not always just sensory neuropathy. It could present as motor neuropathy, and sometimes it is very sudden. I have previously had a patient who I gave EV for 8 months and then he couldn't walk.
Wow.
And the patient had no warning signs of developing neuropathy.
Right.
So I think these are some of the common side effects to keep in mind about EV. Yeah.
Right. Right. No, that's definitely very relevant in our clinical practice day to day. And then are you using any biomarker-driven approach to help you with dosing and
Uh,
de-escalation?
Not yet, but we are collecting ctDNA. So it's ongoing in the pilot trial, and we are also going to have like a phase 2 trial, a multi-institutional study, which was recently funded by DoD, which is going to open in the beginning of next year. And as part of that study, also we will be incorporating ctDNA. And I think it remains to be seen how we begin to incorporate ctDNA in deciding which patients can de-escalate, and if they do de-escalate at some time point, should we re-escalate quickly based on their ctDNA marker. I think those things will be really important to see going forward.
That's very exciting. And will the trial design for the phase 2 be similar to the second cohort of your pilot study?
It's going to be similar, but we are not allowing patients with stable disease to de-escalate. We are only allowing patients with CR and PR, and we will be dropping EV after 6 cycles for all patients attaining a CR or PR.
Wow.
And it's going to be a 97 patient study that with the primary endpoint of 18th month PFS.
Right. Wow, very exciting. Well, thank you so much for joining us. To close out, are there any other studies in the urothelial cancer space that you're excited about?
I definitely am very excited about the ongoing studies in the muscle invasive bladder cancer space in the neoadjuvant and in the adjuvant setting where people are beginning to use EV Pembro and also using ctDNA as biomarkers to de-escalate adjuvant immunotherapy. I think learning things from the adjuvant setting and the neoadjuvant setting would also really help in applying things to our metastatic settings. So I think the trials we are very really looking forward to the data for neoadjuvant EV Pembro
Right.
as well as for adjuvant trials like modern trial.